Welcome to the THOR Table of Knowledge podcast, where we dive deep into the groundbreaking world of trauma care, hemostasis, and oxygenation research. A special thank you to our sponsor, Velico, for their support. Velico is revolutionizing trauma care with their innovative frontline ODP spray-dried plasma system, with the goal of empowering blood centers worldwide to produce dried plasma for transfusions.
I'm here today with Dr. Marty Schreiber, a trauma surgeon from Portland, Oregon. And today I thought we'd talk about how do we change practice in trauma medicine. There's so many changes that are needed, so many new therapies coming down the pike. And when you change practice, what do you use to determine if it's appropriate or not?
Yeah, ideally, we'd like everything to be managed based on randomized controlled trials. But the truth of the matter is that most of the things we do on a daily basis, we'll make 1,000 decisions in one day in an ICU, and most of those decisions there aren't randomized controlled trials to help us make decisions. So we base our decisions on the best available data at the time. And, practices change and that data really changes. So if I'm 62 years old, and throughout my career, I've changed many of the things, and probably more than 50% of the ways I practice in the past have changed. And my mentors taught me things that have proven to not be beneficial. Very little of those changes really are based on randomized controlled trials. So I'll give you a few examples. We were taught that we should, in the ICU, that if there's a problem with the patient, they probably need crystalloid fluids. And we should keep giving crystalloid fluids until the patient's better. But in fact, what was happening is we were making the patients worse. And our observations over time led us to that conclusion that this was not a good practice, and we got away from it. There were very few trials that actually showed that. Another example, needle thoracentesis. That's been a practice taught by ATLS for decades. But you make the observation that when the patients come in with a needle thoracentesis from the field, half the time the needle's not in their chest, and the other half the time they might not have needed the needle thoracentesis. So based on that experience, you change the practice. So you use the best available data that you have.
Right. So that's changing practice, stopping certain therapies when you recognize that they're either unsafe or not working. But what about new therapies? How do you make a decision about starting something new that's on the market?
Yeah, so that's a great question. I think that the answer to that question is, some of it has to do almost like a fad. So I'll give you an example. Recombinant factor 7A. So in about 2000, 2001, 2002, recombinant factor 7A was the drug that our pharmacy paid the most money for of all the drugs in the pharmacy. It was a fad. Everybody started using recombinant factor 7A, and it became part of practice. Trauma surgeons would go to meetings, and they would say, this is the greatest thing on than sliced bread, and we all started using it. But then a randomized trial did come out and show that it really wasn't beneficial, and we stopped.
But we should be starting things based upon a fad, or because something it seemed cool at a meeting, or someone who you respect is using it. What should be driving change when there's a new therapy and there isn't RCT level evidence yet?
So I think that, what can happen, and in the case of factor 7, I think it's true with whole blood as well, is the therapy makes sense. There's a pathophysiology that needs to be corrected. So for instance, coagulopathy. We know that when we gave recombinant factor 7A, patients would come in with an IR of 1.6, and then they get the recombinant factor 7, their IR would be 0.8. So coagulopathy is a problem in trauma. We have a drug that fixes the coagulopathy right away, and it makes sense to us that would be a reasonable therapy. It makes sense that instead of giving components, red cells, plasma, and platelets, if you give whole blood, it's a much simpler therapy, and it would make sense that would be better. But I think when we do change practices based on what we think makes sense, we do need to go back and do the randomized controlled trials to prove that those things are better. So in the case of recombinant factor 7A, we did the trial, it went away. In the case of whole blood, we're doing the trials now. Are they going to show a benefit? Maybe, maybe not. But, randomized controlled trials are not magic, right? Because they can be done well, they can be done poorly. It depends who's going to be enrolled, who's going to be excluded. what drug you're using, is the timing right, is the dosing right. There's a million different variables that have to be managed to have a successful randomized controlled trial. So even randomized controlled trial, and there's been therapies that have been proven by randomized controlled trials. You go back and do another trial and it's no longer effective.
Right. I mean, clearly the quality of trials is essential for interpreting the data and if it should change practice or not. And waiting 10 years to perform a trial before you change a therapy that might be beneficial is putting a lot of patients at risk as well too, if that therapy would improve outcomes. So I agree with you. My approach is to change practice if there's biologic rationale, if the data for the standard therapy isn't strong, and it seems like this therapy is likely, safe. And at the same time, work in parallel to design those trials to see if the change we made was appropriate or not. I completely agree. But when it comes to transfusion medicine, right, changing practice isn't as simple because they're the gatekeepers basically for blood products.
Blood bankers.
So what has been your approach when you want to change practice when it comes to transfusion? How have you worked with your blood bankers there in Portland to make the changes that you had made?
It's a really interesting question. I'm going to be honest with you. Uh, for whatever reason, I believe there's a phenomenon that the local expert, so somebody in your facility, so myself with my blood bankers, I have less of a voice than if I bring somebody from outside. I'll bring you in. I'll bring John Holcomb in. I'll bring in some outside expert and they present the data. And for some reason, that has more effect than an internal person who's, works there and been there. So what I would do is that, I would try to educate the blood bankers. In this particular case, they are the gatekeepers. They need to be educated. And the way we were successful is by educating the blood bankers, and they came along. Now, I just want to bring up another very interesting phenomenon. So I want to talk about, there's the proper trial, which was 1:1:1 plasma to platelets to red cells versus 1:1:2. That trial didn't show a benefit. It was a negative trial. But by doing the trial changed the practice. Even though it was a negative trial, we learned how to do 1:1:1 because the products were delivered in the right ratio, so you had to give them the right ratio. But just doing that trial changed practice, which I think is interesting.
You don't think practice was changed already beforehand? And
No,
ignore the results because it's what their bias was to begin with?
no, and the reason why I say that is because before the proper trial was the prompt trial. And if you looked at all the institutions in the prompt trial, that was an observational trial. The ratio was not 1:1:1. It was closer to 1:1:2 in the prompt trial, which was observational and not interventional. So the standard was 1:1:2. I think another thing that randomized controlled trials may do is teach you how to do an intervention and make people comfortable with that intervention. In fact, in my institution, if I want to change something, I propose a trial because people will go along with the trial as opposed to saying, hey, I want to do this. I want to make this intervention. Example being, somebody's got a feeding tube. They're intubated. Traditionally you stop the feeds if you're going to do an operation on the patient. But there's no reason to stop the feeds if you're not going to be intubating that patient because they're not going to aspirate because you're not intubating.
Right.
So I wanted to change it. I got resistance from the anesthesiologist. I said, okay, let's do a randomized trial. Before you know it, they get comfortable with it and you can change the practice.
Right. Yeah, no, that's innovative or clever. And I agree. And many people seem to be doing that as well too, with these phase 2 type studies that are not powered to determine if there's a difference or not. But then people get to use it so they know how to develop the product, make it available, and then change happens. But when it comes to designing trials, you're a very accomplished trialist. What's the trial that you want to be able to do next? I know, well, Mitchell, what are you doing now? And what's the next trial you want to do if you had access to all the money in the world and could wave a wand and do something?
So the trial that we had started and we really wanted to do was we wanted to do a randomized trial of prothrombic complex concentrate versus placebo in hemorrhagic shock patients in the field. The idea being, again, early correction of coagulopathy would improve outcomes. I think that's an important trial. There's a in-hospital trial that's sponsored by the company. That pre-hospital trial also sponsored by the company. And so I think that I think is a really important trial. We not too long ago completed a randomized trial looking at tranexamic acid, 2 grams in the field for TBI. The practice is sort of changing in hemorrhagic shock, but I think that's an important trial. Should we be doing a 2-gram TXA trial in hemorrhagic shock? Because what happened in Portland, for instance, was we did this trial in TBI. We started giving 2 grams of TXA in the field for TBI, but then the medics just started also giving it for hemorrhagic shock instead of 1 gram and 1 gram, which, what we found in the TBI trials, if you do 1 gram in the field and then 1 gram over 8 hours, only about 75% of the patients actually get the drug.
Right.
So they'll get some part of it, but if you just give the 2 grams up front, you get early administration, a very potent potential benefit, but the patients all get the drug.
Right.
So
Yeah.
so I think it could be worth it to do that in hemorrhagic shock, although the practice is already changing to do that in hemorrhagic shock, and we don't know if that's the right answer.
So you would compare 2 grams IV bolus to what? To 1 gram and then a 1?
Yeah, so ideally 3 groups.
Mhm.
The same exact groups that we had in our TBI trial, which was 2 grams pre-hospital bolus followed by a placebo infusion, 1 gram bolus followed by 1 gram infusion over 8 hours, and placebo infusion over 8 hours. So blinded trial, 3 groups, and take patients in hemorrhagic shock.
Gotcha. Okay. So if you could design your dream trial and get it funded, that's what you would do.
I would do that.
Yeah. Interesting. From my perspective, I think we need to be doing platform trials where we can assess multiple interventions, or what they call domains, to understand what's the best bundle of care for specific patient populations. Because if we continue to do these one intervention at a time trials, we don't know how to put them all together. And that's what we do when we practice medicine. It's not only the antifibrinolytic, it's what's the blood product, what's the calcium replacement or not, what's the ventilator strategy even. So we're working with a few groups to try to put together platform and trauma trials that also do both pre-hospital studies and they continues in hospital. So that's a good question to ask you. Do you think it's appropriate? Should we be doing pre-hospital only trials where the intervention stops when they get to the hospital, or should it continue, if possible, throughout the acute phase of resuscitation?
Yeah, so number one, I completely agree with you. One of the beauties of the platform trial is that you set up the infrastructure. So instead of just getting individual funding for a study, setting up the infrastructure and then dissolving it when the study's done, you have ongoing funding that maintains the infrastructure, allowing you to do numerous interactive studies. And if something's not working, then you try another intervention that you continue from pre-hospital, in-hospital. You're absolutely right. That is the ideal way to do it. I think funding is problematic for that type of thing. How do you manage to keep that going on ad infinitum, and can you do this? But if you're able to do it, that is the ideal way to do it. So the one, I think the LIGHTS trial, Linked Investigations in Trauma, funded by the Department of Defense, has sort of come close to that, is that they've now been funded for somewhere around 10 years. They've got additional 10 years of funding. So they've established the infrastructure, and they are doing multiple, but they're individual trials.
Right.
It's not what you're saying.
They're not targeting platform trials.
Right.
So there was some discussion, and it wasn't, they decided not to do that. But at least they'll be able to provide the preliminary data to design the platform trials. And actually, BARDA is interested in funding trauma platform trials. And actually, our Made It 2 trial in children is a platform trial in trauma, and BARDA wants us to start including adults once we're done with this part of the trial. So there might be an opportunity through BARDA to continue our current platform trial with both children and adults. So that's maybe the last question I'll ask you. We study adults above 18 years or older, or 16 or older, and then we do trials in children, 16 or less. That age is not dependent upon any biology. It's kind of based upon when you graduate high school and on. So moving forward, should we be doing trials in all ages, right? 0 to 90, and then look to see if age is a effect modifier, right? Versus trying to do only studies in children, which is really hard to do.
It's a great question. And I think, when you ask the question, what it makes me think of is the platform mechanism, right? So within that platform mechanism, you could put all appropriate patients in studies. There may be things that you don't want to study in an infant, right? Because we don't have data about safety. But all appropriate patients could be placed in a study using the platform mechanism, and then you individually analyze them statistically to see if there's a difference between the children and adults. And that is going to be 100% more efficient than instead of having individual adult and children studies. I mean, the issue with children is can be more complex, and you would be much more of an expert than I am on this, due to consent issues. And frankly, I have not been involved in it except from informed consent trial in children. Do you have comments on it? In children?
We were able to get EFIC approved with the FDA for our current trauma trial. And there are others that have pediatric sepsis trials that are using EFIC now too. So people think because it's a vulnerable population, it's harder to get EFIC in, but as long as you meet the criteria for EFIC, it's the same as it is for children. And we've been able to get it approved by FDA and single IRBs as well.
So the goal of EFIC is to educate the at-risk population. So in the case of children, are you carrying on the educational effort with the parents or the children or both, or how do you do that?
It's definitely parents, obviously, and teenagers or children that could provide assent kind of, to begin with, can be included in the community consultation process as well.
So a 5-year-old would not be a target for an EFIC educational event.
Correct. Because if they're not able to understand, right, they wouldn't be able to provide assent with standard written informed consent. And it doesn't make any sense to try to get their input in a community consultation process.
Yeah, so I have probably 20 years experience with ethics studies, starting back with the Resuscitation Outcome Consortium. I know nothing about the children.
Yeah.
I think, as someone who specializes in children, I think it would be important for you to educate the rest of us about how to do this in children.
Good idea. Great. Well, Marty, thanks for this very stimulating conversation. I got you to say I was right a few times.
Oh, absolutely.
Which is more than most people get. So thanks a ton, man, and Skold.
Pleasure. Thank you.
That's a wrap for this episode of the THOR Table of Knowledge podcast. A big thank you to our sponsor, Velico, for supporting the advancement of trauma care. Their frontline ODP spray-dried plasma system is paving the way for blood centers globally to produce potentially life-saving plasma for transfusions. Check out our website, www.thornetwork.com, for more podcasts, and join us next time as we continue to explore the cutting-edge science of trauma, hemostasis, and oxygenation. Until then, stay safe and stay informed.